Uh, so, so can we have a slight introduction from all the participants? A brief about their country and their specialty, if they can.
Yes, that would be nice. Dr. Ivan, Dr. Chucks, Dr. Davis, anybody can start. I think
Yeah,
that will
please,
be a great
please.
start to the session.
So, because I don't want it as a monologue, right? It's a dialogue, and teaching is one of my passion, right? So, surgery and teaching surgery and how to diagnose the patients for their better care and their outcomes. That is something which I am very passionate about. So, I am basically working with this BLK-Max hospital for last 14-15 years. I'm director of the department of urology, uro oncology, and kidney transplant. That's about me. And now anybody else, please start telling something about you, your job and country.
Dr. Chucks, can you
Uh,
start with you? Yeah.
I am Dr. Shatu Batkala from Ethiopia. I'm a pediatrician for the last 20 years.
Oh,
I'm
lovely.
practicing in private health sector.
You're most welcome, Dr. Shatu. Great. Ethiopia. I have been to Ethiopia many times. Addis,
Oh,
I love Addis actually, the weather of Addis.
Yeah, so it's like a Nainital
okay.
and Shimla. I attended a
Yes,
boarding school in Nainital, so it's just
yes,
like
yes.
that.
Right. Dr. Chucks.
Good everyone.
Dr.
I
Chucks,
am Dr.
I know about you, I can introduce you, but it'll be better if you introduce yourself. Okay, Dr. Sunday. Uh,
Yeah, well,
yeah,
good
please.
evening.
Good
Good
evening. Please
evening. Good
introduce yourself.
evening.
Yeah, welcome, doctor.
Yes, thank you.
Yeah, Nigeria.
Oh, lovely, lovely.
Yeah, yeah, we are friendly with your people, so we hope to get the best from you.
Perfect.
Yeah,
Your specialty, Dr. Sunday?
yeah, general surgery.
Oh, that's lovely, lovely. So I went to Nigeria also many times. Lagos,
Wow,
yes. Help some
that's
surgeons there.
great.
Helps for the kidney surgeries there. Great.
Okay, we can,
Yeah,
Dr.
Sorry.
Honor, Dr. Wasim,
Yes, yes,
uh, Dr.
I'm
Dab.
Dr. Uro from Nigeria too.
Okay.
Yes, I am an internal practitioner.
Perfect. Thank you very much. Great.
yeah, it queued in through my advert.
Right.
Yes, Dr. Dab. Okay, yeah, please go ahead with your introduction.
Okay,
So many
good
people are
afternoon.
still coming.
Good afternoon, everyone. Good afternoon, Doctor.
Good afternoon. Your specialty, Dr. Dab?
Baron. Okay, my name is Dr. Daap Robzak, a chemical pathologist on training, and I've worked as an accident and emergency doctor for the past 5 years, and
Okay.
yeah, currently I'm running my residency training in chemical pathology, just University Hospital, just Nigeria, Plateau State. So thank you for
Great.
this opportunity. I look forward to learn a lot from this platform.
Perfect. Perfect.
Uh,
I
yeah,
have
thanks.
many Nigerians
Uh,
here, so you people should.
Okay, we have Dr. Atanda Solomon. I think we should quickly, it will be great if all of you can introduce yourselves. We'll
Yes,
quickly
yes, yes.
start the masterclass. Dr. Atanda, Dr. Innocent.
Dr. Wasim.
Yeah, yeah. Good afternoon, Dr. Wasim. Yeah, please go.
Good afternoon, everyone.
Good afternoon, sir. Good afternoon.
I am Dr. Wasim Brahim from Chad.
From Chad.
Yes.
Oh, lovely, lovely, great.
Okay. I'm a general practitioner.
Okay.
Okay, and I work in University Hospital Renaissance, the biggest one in our country in Jamena.
Great. So,
Good afternoon, doctors.
yes, good afternoon, sir. Good afternoon.
Yeah, I'm Dr. Innocent Zili from Kenya.
Kenya. That's great.
Yes, Kenya.
You're most welcome,
Yeah.
Dr. Innocent.
Yeah, thank you very much. I'm a cardiothoracic surgeon resident in Kenya.
Perfect. Perfect. Okay. Now, if all of us, I think everybody has covered their introduction, right?
Good afternoon, doctor.
So, shall we start now? For next half an hour, 1 hour, we'll be discussing about something which is happening in the urology, transplant, and robotics. You know, the beauty of technology. Today, I'm sitting here in Delhi and talking to you in the Africa, multiple countries of Africa, Ethiopia, Nigeria, and all that. So this is the beauty of technology, and similar things are happening in the urology as well. So sometime back, there was robotic surgery being done in a hospital, being a patient being operated in other centers, right? So with the advancements of the technology and the robotics, all these things are a reality now. So next, so modern urology is equivalent to technology. Here we see our theaters full of lasers, mini endoscopes, robots, and lots of other equipments which are very sophisticated and very high-end technology driven. The most common problems in the urology, what we deal with our patients, they have the urinary problems, BPH due to BPH or prostate malignancies, stone cases of small stone, then the bigger stones, and sometimes the stones which are like very tricky, huge stone load. Then kidney transplant. We see lots of patients for the kidney transplant surgery. Across the globe, we are a referral and choices center. We get patients from Africa, Middle East, CIS countries, Fiji, Tuvalu, and many places. Of course, domestic. We have a good burden of patients from the domestic as well. I'll be touching upon Uro Oncology also, little bit about what is the recent in the Uro Oncology and how we are delivering the best care for our urology patients. Very common scenario in urology, like a patient with 50 years, not very old, with some urinary symptoms which are really bothersome, having prostate which is 46 gram, flows are obstructive, and patient is not happy with the medical management. You know, with the medicines also, there are lots of side effects of the medicine. Young men want to preserve their sexual function. The good medicines like sulodocin and sometimes tamsulosin also gives retrograde ejaculation. Okay, so the choice of medicine for these group of patients is either alfujosin. But the problem with alfujosin is it gives them orthostatic hypotension, postural hypotension. So not everybody is able to tolerate alfujosin. Then the option for these kind of patients are, we cannot leave them with these kind of symptoms for a long time. We have to treat, and the minimally invasive treatment options like bipolar TURP, enucleation by the bipolar current, or holmium laser enucleation, thalmium laser enucleation, they are all very sophisticated surgeries. But recently, there are 2, 3 other techniques, or we got these 2, 3 other techniques, which are not even the surgery. These are small OPD procedures. Sometimes in daycare only, we do prostate urolift, iTind, or Rezum. So we have to identify a patient, select our patient, and treat their symptoms in a ways they are most satisfied and least side effect of the patient. So the holmium laser enucleation, that is a good technique, the advanced technique for the prostate surgery. But this is a good technique for the patient, those who are above 60, 70 years, those does not want to preserve their ejaculation. they are okay with their retrograde, they are accepted their retrograde ejaculation. So now the technique which is of very, very, uh, famous in these age group patients is the Urolift. What this is like a small device, Urolift device. Through this device, we clip the prostate and make the prostate open the prostate channel like that. So you can see here like the prostate which is big and occluded. After putting the clips in the prostate and opening the prostate fossa, the prostate becomes open. So these clips, they finally, and because of the shrinkage, the prostate remains in that shape. So symptoms gets improved. That's how the fossa looks like once you put the clips there inside this thing. So the similar kind of things are there, like itin. Itin is a small device where we put a small metallic case kind of thing into the prostate, which opens and squeezes the prostate out. It is a very simple device, very simple to implant inside the prostate. It stays there for 5 days, 6 days, then we remove it. After removal, the prostate remains in that open space. So this is also a good procedure for a young man. Now, the rhizome is again a simple device. We have to put a small needle with the water jet therapy. The prostate gets shrunk. So these three things, which are very, very recent in the urology armamentarium, they are helping many of our patients, those who are young and want to preserve their sexual function. Otherwise, routinely what we are doing is like HOLAP or bipolar TURP. These are the standard of care. So none of your patient will require an open surgery in this era. Okay, so these techniques, if the prostate size, which is very big, bigger than 200 grams, 250, 300 grams, then we do a robotic surgery and do robotic simple prostatectomy. Otherwise, I have operated upon a whole size of around 300 gram, 350 gram also, and 300 gram in one session. Routinely, we have done many cases like that. Now, something in the stone management. So I'll tell you, in the stone, for last 15 years, I have never given any incision for a stone patient. Whatever size of the stone, we are treating that with the lasers or endoscopes. Endoscopes are like for the ureteric stones or the stones in the kidney. You can see here, this is the flexible ureteroscope. With the flexible ureteroscope, we go inside the PCS and fragment the stone with the laser and crush the stone, basket it out and clear the stones. That's how the RIRS process is being done. So advantage of RIRS is like there are no holes, no cut, no blood, and patient usually stays for 1 day. It is the safest procedure for the kidney stone removal. Sometimes the stone of size around 2.5 to 3 centimeter also can be cleared with the RIRS. So with the thulium fiber laser, this is a very kind of a rewarding surgery for the patient, right? That's how the holmium laser looks like, and holmium laser fragments the stone. When the stone size is like this, here you can notice there is no kidney, all the stones, full of stones, both the kidneys. These kind of stones, yes, these stones also can be treated with the PCNL. In this case, we need to do a 3 puncture techniques and remove all the stones through the kidney tract. Sometimes you see these kind of patients, those who have bony deformities, and you see the stone, how big is the stone? That kind of patient we did easily with the robot assisted pyelolithotomy. So there were 2-3 small holes, and through the robotic assistance, we could remove all the stones. Okay, so that thing is very clear. For stone management, the early treatment are the best treatment, and for the stone, the stones are never a silent disease. We have never seen a patient having a stone and they are silent, and you are ignoring the patients with the, if there are stones and they are not getting treatment for it, that means they're ignoring the disease. So it is very important. Stones are metabolic disease. They increase in size, they obstruct the urinary passage, they damage the kidney. So all the stones need some attention, medical attention. Now, I'll tell you something about erectile dysfunction. So, very common male problem. So for erectile dysfunction, actually, this latest treatment, which is like low intensity shock wave therapy, and the intracavernosal injections and the PRP treatment. So all these things, they are helping our patients for the better erectile function. But if these conservative treatments are not helping the patient, then we do penile implants. So how the penile implant works, this is a penile prosthesis. Here we put one mechanical device, pump here, one reservoir full of the saline, and there are two cylinders. So from this reservoir, through this pump, the fluid goes inside the cylinder and we get the erect penis like this. So we do patients, those who have kind of end-stage penile arterial insufficiency, post-radical prostatectomies sometimes. So we get many patients from Africa, so they were treated there with the open radical prostatectomy. They lost their continence also sometimes and lost their erectile function. Then we put these kind of penile implant for those patients for their erectile function. So for the infertility thing, infertility, when there is obstructive azoospermia, in that scenario, we have to confirm the diagnosis. If the testes are good, there are good spermatogenesis inside the testes, then we do microvasoepididymal anastomosis. So these patients, when they get this surgery, there are around 35 to 40% chance that they will have sperms in their ejaculate. So something about kidney transplant. We are doing here almost all kind of kidney transplant, the high risk to multiple time sensitized patient, all that. And all of you will agree that kidney failure is a rapidly growing problem.
Dr. Rana, can I interrupt you? Do you want
please, sir.
questions in runtime or at the end of it? Because there's a question from Dr. Davis. Should I
Okay,
share it?
no problem.
now?
We can take questions right now also. That's
Okay.
I'm fine with that.
So he wants you to explain more on shock therapy and PRP or RPR for erectile dysfunction.
Okay, so shockwave therapy is like you can see in this small picture, that's a device which generates the piezoelectric current. So these are basically shock waves, just like the piezoelectric current we have in this lithotripter, the stone fragmentation device. This is a mini version of that. So how it works, like we give around 2000 shocks into the corporas. These shocks, they are repeated sometimes once in a week for 6 sessions, or sometimes twice in a month for 3 months, like that. The mechanism of the shockwave therapy is like they generates neoangiogenesis. So there are growth factors which get stimulated and neoangiogenesis happens inside the corpora muscles. So the success rate of these kind of treatment is around 65 to 70%, but we have to carefully select our patient. It's a good technique for diabetic patient, those who have the borderline erectile functions and they are diabetic, which is well controlled. They get benefit out of the low intensity shockwave therapy. So similarly with the PRP also, but the intracavernosal injections, they are a good technique on demand. We teach patients, we give them a dose of the injections and they self-inject themselves, right? So they get their erections after that. Is that answers your question?
Dr. Davis.
Yes, sir. Yes. Yeah.
Okay.
Maybe more about the PRP.
Okay, so PRP for erectile dysfunction is like we have to take 5 ml blood from the patient, then it goes for the centrifugation and the PRP rich concentrate we get from the lab. That we inject around 1 ml into each corpora. So the sessions are like once in a week for 3 sessions. The effect of the PRP is around 60% patient. Again, a carefully selected patient, diabetic, well controlled with the vasculogenic erectile dysfunction. It's not a good treatment for the neurogenic erectile dysfunction. Okay. So these both modality, they are helping the patient by terms of the neoangiogenesis mechanism.
Thank you
right?
so much.
Great. So anything about the penile implant, you got it? So penile implant is a basically technique when everything has failed. So none of my patient gets the penile implant upfront in their treatment line. I take them along with their initial counseling sessions, after that medicines, then injections, PRP, plasma, and like this. So this is only when nothing is working out. This is when there are neurogenic problem, there are complete fibrosed penis, or they are not getting any effect out after the injections and all. So this treatment is a last resort for the patient, right? So now shall we start something discussing about kidney transplant?
Yes, sir. Yes, sir.
Okay. So kidney failure is a rapidly growing problem. All of us will agree. Why? Because of diabetes being more number of patients of diabetes, hypertension, cardiac issues, and obesity also. These things are contributing for their poor kidney function. So whenever a patient gets diagnosed with the kidney failure, it becomes a big challenge for the family. The challenge is the acceptance. Why it has happened with me? That day when we tell somebody like your kidneys are not working, you will require dialysis or transplant, that day is really a sad day for us also and for the family also, the day of doom. Then it comes the role of family and society and healthcare providers for their counseling and tell them and show them the stats about it. So it's not like that they only suffer, it has happened with them only. There are many patients, those are also being affected by the kidney failure. And this all has happened because of their proper, they're not taking care of their kidney beforehand. So for the kidney, what I always tell my patients and the fellow colleagues, like kidneys are very silent organ until unless we diagnose them by doing some investigations. When we see the patients having the symptoms of kidney failure, that's too late. You have to get them screened, do their serum creatinine, check their urine for proteins and urine examination, and get their ultrasound. Ultrasound is a very simple and very important tool for the kidney failure. It tells us many things about the kidney size, kidney, sometimes the tumor also we pick up on this routine ultrasound, and we can cure these kind of patients by doing a simple surgery. So ultrasound, creatinine, and urine routine, I request everybody should do at least once in a year. That is the important thing. So the second challenge for these kind of patients becomes the choosing the right way of RRT. Sometimes we see a gentleman of 80 years, they are like, no, I have everything, I have money, I have a donor also, do my transplant. We refuse them. Above 80, the transplant is not a good option because it will require lots of immunosuppressions. There will be more complications related to the immunosuppression. So the transplant is a good modality for young patients, preferably below 70 years of age. Up to 60, it is the best modality. So the kidney transplant also, we have to choose our patients so as to give them best quality of life afterwards. There is no doubt about it. Transplant is all the time better than a dialysis. Dialysis patients, they have a miserable life. They are on dialysis twice or thrice in a week. They are most often in the hospital only. They are never free from their kidney problem. After the transplant, they just take the immunosuppressions and they have a good quality of life. So for the kidney failure patient, the first step becomes their fistula creation, because when they are getting prepared for the kidney transplant, they have to receive that hemodialysis, and for that we have to make a AV fistula. Why do create a AV fistula? Because for the dialysis machine, at least 2200 ml per minute flow volume is required for the blood to get filtered. Other option is the CAPD catheter. CAPD catheter is also a good technique for dialysis. So for these patients, basically, they can manage their dialysis sessions at home. But the problem here is the infections. If there is any breach in the sterility, there will be infection, and these infections are sometimes very dangerous for the patient. So the third challenge for these kind of patients is like having someone to donate their kidneys. There has to be some healthy person volunteer, those who can help their family members and donate one kidney. As of government law in India, we only do live related transplants are permissible from the outside nationals, right? Only live related, first degree relatives and the grandparents. And we are doing here live related and cadaver transplant also. Our center is doing routinely the cadaver transplants as well. And for all the transplants, we have to get the authorization by the state committee for unrelated transplant and the foreign national. So that's how the kidney is from this. Actually, this video is not. So I'll show the videos at the end of the slides, right? So in this flow, videos are not getting played. Once the kidney is harvested, we perfuse that kidney, clear their clotted blood. Then this kidney is transplanted into the iliac fossa of the patient. Okay, just a second. If you want to see this video, I'll show from here. That's how the kidney transplant we do. So in this kidney transplant is being done robotically. First thing is like doing a venous anastomosis like this. So vein is being clamped both sides, and with this Gore-Tex suture we are suturing here. So there are some advantages of robotic transplant, like a small incision, and it's a good technique for obese patients, those who have good vessels but very obese. Otherwise, also routinely we are doing a mini incision kidney transplant. So my incisions are hardly 8 or 9 centimeters just to put the kidney down into the fossa. And we do a special, after the special retractor available with us, we do a good anastomosis by our vision under magnification. And for those patients, those who are obese, those who are very cosmetic concerned, we do robotic transplant also routinely. So that's how the vein is being anastomosed, and once the vein is done, then the arteries will be clamped and artery will be anastomosed here. Problem is like while this on Zoom, I cannot fast forward it. Okay. Now going back to my main presentation. So meanwhile, we can discuss any question if you have.
Sir, a very frequent question that we face is around, how do you, I mean, and it will be educational, like, how do you determine donor compatibility? Like, while we know that in India, we are doing kidney transplants for unmatched blood groups also, but a
Yes.
basic understanding of it, because when they make a referral, those kind of questions routinely come up. And around the regulations, like there are different regulations for Indian citizens and foreign citizens. They have to come with a willing donor, related donor. So some clarity around
Regulations are
that.
same here for Indian donor as well as for the international donors. So I'll give you the thumb rule. For a kidney patient, there has to be a related donor in the family. First, the family related donors. So husband, wife, children donating to the parent, parent donating to the children, grandparent, like this. Okay. If there is nobody in the close family, then we can move to extended family. That's it. There has to be a DNA match, because all the patients we do a DNA, confirm their compatibility and the family tree. So no transplant we do without their having a DNA matched and with the confirming their relationship. That is very clear in our hospital.
So, sir, like with DNA matching, like first cousins, second cousins, third cousins, they would be allowed. They would be considered related donors.
No, that will be only when there is nobody in the near relation, and that too for their cousin also we have to do 2 or 3 DNAs so that we establish their relationship. It's not like first, second, third cousins are allowed. No.
Okay, so that relationship test, whether they're related, is done through DNA.
Through DNA,
Not,
through
not,
all,
not just
and everything
affiliated.
is the embassy checks and verify all the relationships and documents, then only.
Okay. Now,
And
sir,
this is when the relationship are. Otherwise, if there is any other problem, like there is blood group mismatch, that we can tackle. So usually we prefer that blood group compatible. So for a recipient, either A donor or O donor, likewise B recipient, B donor or O donor. If there is some blood group incompatibility, like recipient is A and donor is B, we do a titer. If this IgG titers, IgM titers, they are within a range of around up to 164, 128, we do their plasma filtration, sometimes they filter application and reduce their titer and do a successful transplant. That is possible.
okay. So we have a question from Dr. Isaiah Mando. The question is, how do you manage kidney transplants in patients with HIV, or whose,
Okay.
or second part to is, if not HIV, whose immunity is already compromised?
Perfect. So we have now I can give answer this question with the authority that I have done many patients of the HIV. These HIV patients, they do fairly well. Actually, we take care of their CD4 count initially before, because the treatment of these kind of patients that starts once they are back home with you only. We start communicating for these patients beforehand, and we request you to keep them under good observation, good medical care until unless they are fit for transplant. We do their kind of good medical management along with the proper CD4 count. If this is a suitable category, then only we ask them that now they can travel. Because the immediate transplant risk in HIV are not much. They are same as in other patients. But the later complications like the immunocompromised infection-related complication, they are more. But we have to be a little more careful in the immunosuppression. Sometimes in HIV, we don't give them routine ATG. We either induct them with the Simulect, that is a good molecule with that. So the immunities are not so much down and they can withstand their transplant and they can have infection control afterwards.
Okay.
Like that.
So, with this, I have one question, and we also face it. So, when doctors they make referral, by the time patient comes on a consultation with you, there are
Mhm.
multiple steps, counseling and guidance going back and forth. One
Yes.
question that often comes up with, okay, while we screen the family for a suitable donor, what are the investigations that can be done, and how do we understand who is a match?
Perfect. So the basic investigation starts with CBC, KFT, their blood group, their sugar monitoring, ultrasound, whole abdomen, urine routine, and urine culture. So if everything is within limit, both the kidneys are good, these tests, this sugar is also good and there is no problem, then we tell them to do a level 2 investigations. Level 2 investigations, like if there is some facilities of getting a DTPA, CT urography, CT renal angiography, or cross match possibility, then you do that. If not, and the family is close related kind of patient, then sometimes, because from some countries there CT is also not possible, DTP is not possible, we tell them show us the ultrasound report, show us the basic investigation. If they are good, then we tell them to travel here and we do the further investigation here only.
Dr. Rana, is it possible for you to shed more light on, like you discussed, blood compatible transplants?
Yes.
uh, like blood non-compatible transplants are also being done. First, is my understanding correct? Because I keep reading the news. Success.
Yes, blood incompatible we are doing routinely. So they are not the first choice for the transplant. They are the second choice. So first choice is always blood compatible. If there nobody in the family who is having blood compatible donor, then the ABO incompatibility comes. In the ABO incompatibility, first thing is the plasma titer. How much are the antibodies in the recipient against that blood group? If these antibodies are up to 1:4, 1:8, that means it is as good as ABO compatible transplant. I hope you understand about the antibody game. So if I'm a B positive blood group, B, so I'll have antibody against A. That's how if I get the A blood group, then these antibodies will start creating the reaction inside my body. The same thing happens for the transplant as well. So if these antibodies I do, their count very minimal. So these antibodies will not affect the graft. This is the hypothesis, and it is a successful hypothesis. So we are doing the ABO incompatible transplant. But the problem ABO incompatible is like the success is slightly lesser than the normal transplant. It is not equivalent. That thing is very clear because sometimes there is rejection, hyperacute rejection. It happens 1 in 50 patients, but it happens. That's why the choice of the kidney transplant in this is ABO compatible only.
Okay.
Incompatible when the titers are low, and that too when we do a good plasmapheresis, give them rituximab 15 days prior. So the immunosuppression protocol is different here. We check the titers 15 days prior, we give them injection rituximab. Then 2 or 3 days prior to the transplant, we give a plasmapheresis session and check the titers daily. Some of the patients, they have a rebound titer very quickly. These patients are managed with the plasma filtration around the clock. And when the titers are at the very less acceptable range, in that time, at the time we shift these patients for the kidney transplant.
Okay. So, sir, there's a question from Dr. Isaiah. He's asking you to state again the level of antibodies as standard for incompatible transplant because he could not catch it clearly.
Okay, so the level of antibody, there are two kinds of IgG and IgM. IgG is the antibody which are very significant for the transplant. Here, if these antibodies are 1:4 or 1:8, that is the acceptable transplant antibodies. If it is more than that, like 1:16, 1:32, 1:64, so up to 1:64, 1 or 2 sessions of plasmapheresis is good enough. If they are more than that, 1:128 or 1:256, that time we have to use a column. So column gives the filtration, and the glycoabsorbent on the column filters absorbs the immunoabsorption happens, and these antibodies get attacked with the column. So that's how it reduces their titer. So once the titers they are less than 1:8, then we do transplant.
Okay. So there's
Am I
question.
clear?
There's question from Dr. Ivan. So can we risk for transplant even when the HLA is low? He's talking about human leukocyte antigen. So when the HLA of donor is low, both donor and recipient is low, can we risk transplant?
Yes, the HLA compatibility is not a big problem. Actually, sometimes the husband wife, there are no HLA match. Okay, so still in the okay, I'll tell you how it works. So for a transplant compatibility, first thing we do is the cross match. Usually this is a CDC cross match. If the CDC cross match is negative, and the second thing is like flow cross match. If these two cross matches are negative, CDC is the complement dependent cytotoxicity, and flow cross match is like the immunobead cytotox. These are negative. That means this is good case and we can proceed with the transplant. If CDC is negative and flow is positive, then we have to do other tests like DSA, donor specific antibody level, and by the SAB method, single antigen bead. These are little more sophisticated tests. Here we can identify how much are the MFI, So what is the risk of this particular antigen getting represented inside the recipient and getting which can danger the kidney? So if the MFI is up to 1500 or 2000, it's no problem. If it is more than 500, again we have to do the plasmapheresis and reduce their levels. So that's how this thing works. If there is HLA incompatibility, there is no problem. There should be no antibodies against that HLA. That is the important thing.
Uh,
Okay, am I clear?
Dr. Ivan, is it clear now?
Right,
Uh,
sir?
yeah.
Okay, now let's proceed with the standard immunosuppressions like the steroid, tacrolimus, cyclosporin, mycophenolate. Usually these patients get 3 drugs immunosuppression regime. So far we have done close to around 1100 kidney transplant at BLK-Max. Now the number is more than that. This was the data we analyzed in the beginning of this year. So out of these patients, there are multiple patients, those who are HIV positive, HBs antigen positive, HCV positive, dual virus positive also. And we did around 25 pediatric transplants. For the pediatric transplant, pediatrics actually the cases they are, you cannot keep them alive on dialysis. That is very, very fundamentally clear. The pediatric patient, they get a good life only after the kidney transplant. Their transplants are a little challenging, but we have done multiple of them. So they are very, very happy, and the outcomes, the long-term outcomes are very, very rewarding. So most of our patients, when they at the time of discharge, their creatinine is around 0.9 or 1.2. As they gets the more immunosuppressions and better titration of that, the creatinine behaves and it becomes around 0.9 or 1. All right, so the kidney transplant is not very, very simple thing. It's not an operation to be taken lightly. Kidneys are precious and they're hard to come by. Or because getting a donor in the family is really, really a challenge nowadays. The surgical accuracy is critical, and the cadaveric transplant is the possible key to match the supply demand gap. So back home in your country also, if you want to get the transplant thing done, so it is very important to get the cadaveric program also done. Renal transplant is like a marriage, blessings for the most, curse for some, and but a risk for all. So actually, we have mentored transplant program in multiple countries. So in Dar es Salaam also, Ethiopia, the transplant was started by the BLK team only. So others, we are for other centers also, we are mentor for their surgical training. They send some patient, some nurse, doctors here at BLK. We train them, we handhold them for their initiation of transplant program so as they can help their patients back home in their country. Now I'll share something about the evolution for the modern surgical techniques. You know, the initial era was of open surgeries. The big surgeon used to give big incisions. That's how they were famous. Then came the minimally invasive surgery, laparoscopic. Now this is the era of Da Vinci robotic systems. In our hospital, we have 2 robotic systems like two Da Vinci systems, and one is SSI Mantra. SSI Mantra is made in India robot. It is cheap and it is equally good as Da Vinci, but slightly slower than that. So here I'll show you some of the surgeries done by me on the robotic system. So we'll discuss something about the application in the prostate surgery, application in the bladder, application in kidney and kidney transplant. So that's how the robotic endoscopic instrument looks like. This is a 3D vision here. So the vision is around 4 to 5 times magnified. You can see the artery and vein very well, and bleeders are well controlled before in time, so the blood loss is less in the robotic surgery. What changes from the laparoscopy here is like surgeon sits on the machine. There are no shoulder strain, no hand tremors. Camera control is with the surgeon, and the good vision and the magnifications give the surgical accuracy. And this accuracy is translated for the better patient outcomes. So for the patient, it is more precise surgery, less blood loss, early recovery, and less morbidity. So these patients, they have shorter hospital stay, they have faster recovery, less pain, less risk of complications, and that's how they join their work quickly. For the prostate, there is no doubt about it. Robotic surgery is the best modality for radical prostatectomy. It has reduced the blood loss from 700, 800, what used to be the standard for the open prostatectomy, to the 100 ml now. And it's most of my patients after robotic prostatectomy, they are back home after 3 days, and they are without catheter after 2 weeks, or it depends, around 2 to 3 weeks like. So I'll show you some of the videos of the robotic surgeries.
We have a question from Dr. Isaiah on kidney transplant around
Okay.
caregivers. So how do you easily get compatible caregivers donation for the kidney transplant? What is the timing?
Okay, so very interesting question. For kidney cadaveric transplant, the flow of events happens like whenever there is a brain dead patient anywhere in the Delhi NCR, there is one organization, NOTO, the National Organ and Tissue Retrieval Authority. So this organization gets the call that this so and so hospital is having a brain dead patient. This brain dead patient, then this NOTO guides them that you carry out the BSD declaration, and this certification has to happen in the hospital by the three persons. One is the primary caregiver of that patient, other is the neurointensivist or neurosurgeon, or a anesthetist of equally expertise. When these two persons, they declare the brainstem death for that patient, then the medical administrations, they get the form signed by the next of the kin. Once these family, they are happy to donate their organs for their family member, then you get their consent for the kidney, liver, cornea, heart, depending on their organ status. Then they tell this message to the NOTO again, that this family is willing to donate all these organs. Now they have a wait list of patients in various hospitals, and that is by the turn. It's not like if I have a brain dead patient in my hospital and I can do a transplant and get the kidney from that patient and do a transplant by my. No, there has to be a central regulating committee which allow us to that this is now your turn. Now you can call your waitlist patient and do this transplant. Am I clear in that?
Yeah, and so generally timing, how long does this? I mean, there's many steps, so much coordination with government authority. How much time?
Yes. So it's an overnight job. So 12 hours job. So first BSD declaration, after 2 hours, the second BSD declaration. Once the declaration happens, then we start informing our patients that yes, we have this cadaveric donor available. Then they start preparing and come. We do their dialysis, do the cross match. So everything happens simultaneously. So within 6 hours, we get the cross match report. Once the cross match report is with us and it's negative, then we start with the organ harvesting. So the organ harvesting happens in that center. I send my team colleague to harvest the kidney there. At the same time, I prepare the recipient here in my hospital so as I do the transplant as quickly as I get the kidney from there.
Sir, one question that we very often face is, I mean, for knowledge, the success rates of these transplants. There's a lot of information and misinformation out there. But as a surgeon, yeah.
The kidney transplant success, one thing is very clear, it is always better than patient on dialysis. Okay. So if you compare a patient on dialysis, a 25 years man on dialysis, he will not live after 4 or 5 years because of the many dialysis complications. So the transplant is around 97% successful working in first year. Second year, around 95 to 93% patients, they have a good life with the good graft. If we see after 10 years, it is around 75 to 80%. If I see after 15 years, around 60% of graft and patients, they are alive.
So another question, like misconception in terms of normal public like us, that one a donor donating a kidney, now patient and donor, they both are with one kidney, better for patient rather than any kidney. Any lifestyle risks, complications, general health challenges for the donor.
Okay, so what happens? For the kidney donation, when we accept a patient, we do such a thorough medical workup that if there is any problem in the kidney or anywhere in the body, we refuse that donor. Okay, so by that mandate, the donor, they outlive their life as per their peers. So what we usually see, and it's a documented evidence that donors, they are healthier than their peer group and they are living a happier life because the act of donation itself gives them a pride that they have helped their family member and they are worth of it, right? So that act of donation helps them to live more. Second thing, when we do a medical checkup, they are sometimes we find they have some medical problem which was addressed, treated before their donation, right? So if they live with that problem, that could have damaged their kidneys and them. So I'll give you one example. When a transplant worker was started for a gentleman, he was otherwise okay. There was some problem with the kidney. There is mild hydronephrosis. So that kidney had a small stone and some stricture in that ureter, upper ureter. So he was neglecting that stone for a long time. We did workup. We took out that kidney only with the stone. We removed the stone, opened that passage, and did the transplant and took that kidney out of that donor and gave that kidney to the recipient. So that's how the normal kidney stays with the donor. Donor actually, they are healthy before transplant and they are healthy after donation as well. That is, they are not the patient for us. Never. Is that answers your question?
Yes, sir. I mean, it actually, the stats that you use that they outlive the peers, like
Yes, they
answers,
outlive.
answers.
They outlive in their health and happiness both.
Yeah. Maybe, sir, that as you said, the joy of giving also contributes to overall happiness.
100%. That is the fact.
So now we have a question from Dr. Ivan. So what can be done for cases of transplant rejection where the antibody attacks the new kidney?
Okay, so much interesting questions are coming up. Great. So the rejection is the truth for the transplant. Sometimes it happens in the early phase, like 1 or 2 weeks after the transplant. With this good immunosuppressions, I have not seen a hyperacute rejections for last 10, 12 years now in the ABO compatible. In ABO incompatible, yes, it can happen. So the hyperacute thing is over. The treatment of hyperacute is also nowadays is little more advanced now. So we'll talk about acute and the chronic rejections. For the acute rejection, there are two kinds of things. It's a cellular mediated or what we call like ACR or AMR, antibody mediated. For that, we have to do a kidney biopsy. So rejection can happen anytime in the kidney transplant patient, but there are various clues by which we can identify them early. Like patient is having a slow decline in creatinine. The creatinine, which was very low, 0.9, 0.7, and its stories start creeping up. These are two indications like there is something going inside the kidney, maybe some rejection. In that scenario, we do a kidney biopsy. Biopsy will tell us whether this is a ACR or AMR. Depending on type of rejection, we have to treat them. Sometimes we do simple methylprednisolone pulse. If that is not working, then ATG. If it's not working, then the plasmapheresis. Like this, the treatment happens. And most of the rejection in today's time, they are reversible. If this rejection is reversed, then kidney automatically adapt to it. There is the problem happens when the rejections are delayed, treated not very promptly. Then the problem happens. Otherwise, rejections are easy to manage,
Okay.
and the kidney function after the rejection recovery.
Dr. Rana, you had discussed like those survival rates at 1 year, then at 5 years, 10 years, so on and so forth. So, like the mortality, it decreases. Like at 1 year, it was 97%, at 2 years, it was 95%, and then at 5 years, it was lower. So, is the rejection happening later on, or is something other?
Yes, rejection can happen anytime. There are late rejections also. That's how it is very important. Once the transplant is done, for my international patient, most often, once the transplant is done, I give them my personal number, my secretary number, coordinators also, because they have to be in our touch. Transplant rejection can happen anytime. But as the time advances, the rate of rejections are less, less, and less. I have seen many patients. I have a patient who is now around 45, 48, and we did that his transplant in 2009. So almost around 15, 16 years back. He's with 0.9 creatinine. Mother was donor that time. Mother is alive now also, and he's doing good. He's manager in some bank. So the transplant, yes, that is the most important thing. They have to be on follow-up. Every 3 months, routinely, they should do their creatinine testing, stick to their and the immunosuppression medicines, check their urine routine examination. The proteins in the urine, this is the first marker that the kidneys are showing some problem.
Thank you, Doctor. And highlighting the importance of follow-up. Like at Jivo, we do it very diligently. Many times, let's say a patient got spine surgery done here by Dr. Girdhar. Dr. Girdhar would ask for review after 6 months. The patient wants to come, but with doctor here in BLK and the local doctor there, many times all it requires as the first is just X-ray, and doctor is able to advise how they're doing. So with a local doctor there in Jivo model, they can do regular follow-up, and if any sign that can be escalated. So, sir, now
Yeah.
another follow-up question comes is, let's say 5 years down the line, the patient is showing sign of creatinine increases and you suspect that it might be rejection. How much window do they have? As you said that rejection is reversible with the right intervention in the right time. So let's say somebody is in Nigeria, 5 years down the line, indications start coming in. So they will have to make trip to India. So how much window of time is there to do the right intervention?
Yes, for that also there are various mechanisms. If there is the creatinine which is starting increasing, urine shows protein, and we are suspecting rejection. And if there is some facility of doing kidney biopsy there, so most of our transplant patients, they follow with their nephrologist back there. So in Ethiopia, I'm very sure there are Dr. Shu and there are many other nephrologists, those who can discuss with us like this patient is showing some signs of rejection. They do transplant biopsy there. They send biopsies sometime to India, sometime there in their country also they get some report. If it confirms, we just on telephonically, because nowadays the medicines are available there also in Tanzania. They treat them with the ATG, Samulex, methylpred. So that is quite possible that they can treat them. If it is not possible, what we do, we advise them to increase their steroid dose. Whatever they are taking, we advise them to increase. We tell them that this is the right dose for you for time being. Then they can plan their travel back here. It
Okay.
is doable because the rejections are not like it starts and it kills the kidney immediately. They are
Okay.
small.
So it's
So
not an
we,
overnight crisis. It is manageable with the doctor
yes, it is
coordinating.
manageable. It is
And
not the overnight emergency.
okay.
Overnight emergency rejections, they usually happen very early. So as it is patient after transplant, they stay back in India for 2 months or 3 months. That time, if that time everything happens perfect, that means the chance of these kind of severe rejection in future are very less.
So now we have a lot of follow-up questions, sir. So the question
Yes,
from
we have many
Dr.
patients. Those.
Dr. Dap is, first, thank you for the presentation, Dr. Yajvendra. And now the question is, which is almost everybody knows, what is the cost implication of kidney transplant? That is first question, question 1A. Second question for him is, what are the criteria for donor selection? I think you covered it, but I mean, some repetition would help. And
Mhm,
what stage of kidney failure do you advise for a transplant? You covered it, but a recap would help. So
mhm,
these are three questions from Dr. Dap. Then I'll go to
mhm.
others once you answer.
No problem. So just for my clarification, this Zoom meeting will go on, right? There is no time bound.
No, sir, it was, we have already exceeded the
Why not?
time by 8 minutes. It was supposed to be 1 hour, but we have few questions, sir. If you are ready to
No, no,
extend.
no. That I am not worried about time, but the Zoom, the link will not expire, right?
No,
Link
no,
will
no,
not
no.
expire.
No, no, we can go on all night, sir, if people want to ask you questions.
Then it's
So,
fine.
yeah.
Okay. Okay, perfect, perfect. So I'll answer that. So regarding the cost implication, I'll tell you, we are the cheap and best hospital in Delhi NCR. One thing I am very clear. For the transplant, the packages are so nominal. So I have been to, as I told you that I was mentor to many centers in Ghana and all these centers like, so I know the cost there. So it is much cheaper. Patient comes here, stays here, then also they save money, get their medicine and go back to Africa. That much I can tell you. So it is somewhere around 13,000, 14,000 US dollar for the transplant package. For the routine mini incision laparoscopic kidney transplant, when the patient they want more cosmetic and do the robotic surgery, it is 3,000 additional to that routine one. Right. The second question was the donor workup. I told you like the initial transplant workup phase, CBC, KFT, blood sugar, urine, and the ultrasound has to be there. If the same blood group is there and most of the important things are matching, then go for the next line investigation, which are DTPA, CT renal angiography, and the cross match. If it is possible in your country, do that. Otherwise, send us the investigation and send the patient here.
And the third part of the question was at what stage of kidney failure? You discuss about selection of patient for transplant, so but if you can do a
Yeah.
recap, do you advise for a transplant? I think you covered age factor, etc., all that.
Okay, no problem. I'll, for the revision say, a patient who is having creatinine more than 7, having a sign symptom of the fluid overload or hyperkalemia, and the kidneys which are shrunk in size, small, less urine output, and the PTH which is more than the normal range, that means the kidneys are not getting reversed. These patients, we have to start them on renal replacement treatment. So back home, all these patients, you have to stabilize them on hemodialysis. Once they're stable on the hemodialysis, in the meanwhile, you start looking for their donor in their family and travel plan to India.
Okay.
So at BLK-Max, we help them. We help them with the visa process also. Our international team, along with the Varun and all, they will coordinate everything point to point so that your patients are in comfort zone.
So you also covered in this, like I especially recall you covered that somebody at 80 had a donor wanted, but you advise against it. Like there's an age cutoff, like for the patient.
Yes, yes, yes. So basically, it's more of the more than the number, more of the physiological age of patient. If a gentleman who is 80, but it is his chronological age, but he is 100% fit and active and have a donor, and we find if it is like not immunocompromised, then we can still think for it. But as a thumb rule, anybody above 80, the transplant is not the best option for him. Let them be on the dialysis. We are not offering transplant for each and everyone. No, we have to select a patient for the transplant so as our transplant they do better and they get best out of their donor. Basically, they get best for their kidney.
Okay. So there's a question from Dr. Isaiah. What is the mean time post-transplant? Uh, what is the mean time post-transplant which is meticulously needed for surveillance as far as the rejection is concerned? Like you said, in the beginning, the risk is higher after 2 months,
Yes.
but I mean, it could better come from you, sir.
Yes, yes. So initially for 2-3 months, they are really critical for these patients. If they do well, then later on the chance of rejections are less. Later on, rejection happens because of the problem and the some failure on part of the patient. One of my patient actually, he was a good gentleman. We did transplant. He was a young 22-year person. We did transplant. He was doing perfectly fine till 26 age. He was about to get married. In that marriage, his own marriage celebrations, for 3 days, he forgot to take immunosuppression. You know it? What will happen now?
Okay,
Kidney
so
got rejected.
that brings me a question. So, do they have to be on immunosuppressants for life after kidney transplant?
100%. 100%. So they will take immunosuppression by morning and evening by watch, the same dose what we tell them. And actually these medicine, they keep their immunity in the silent mode. If you are not taking immunosuppression, your immunity will get activated and it will kill your kidney.
And so, does it have another impact like immunity low, then other risk of other infections, and the cost implication of
That
being
is
on the
the
drug?
art of balancing. Art of balancing. We have to keep the immunity as low as it is good for the kidney and does not risk patient for the opportunistic infection. This is the art of proper immunosuppression balancing, and
And what
easily
are
monitored nowadays. No
and
problem.
are these drugs as expensive as cancer immunosuppressant drugs, or are they?
No, 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 no. They are not. So if I tell you, most of the transplant patients after transplant, after 2 months, initially for 2 3 months, the dose are higher. After 3 months, so it is like around $100 per month.
Okay.
But for Indian currency, it is like 8,000. 8,000 is like $10, not 100.
No, no, sir. 8,000 would be $100.
$100. Yes, yes, $100 per month.
Okay. Okay. But then availability of drugs, but okay, they can coordinate with India and buy
Yes, yes, yes.
long time.
Many of my patients, what they usually do, what almost all of this, my smart patient, they are doing like they come every year, they take their medicine and go back. They save their money, get a full checkup here, and they take their medicine for 1 year. There is no problem in that.
Okay. So now interesting questions are from Dr. Shamsu. Although you answered, but again, recap will be required. Thank you for the presentation. What is the survival rate after kidney transplant? Or after how many years would the patient likely need another transplant if they survive?
Okay, so I'll tell you, if the patient is very careful about their immunosuppression and their lifestyle. So the problem happens here, the patient become casual after some years, maybe after 5 years or 8 years, they become casual. They start taking the things as for granted. If they do so, the kidney gets problem, there will be infection, and they will land up in the second transplant scenario. So we do second transplant once the kidney has totally failed. They are back on the dialysis. So I have done third transplant also. So, why with first transplant, then second transplant, then I did a third transplant as well. So these kind of options are also possible. But initial counseling, we tell them very clearly that this is your next life. Take so much precaution. So you have to prolong your graft survival. Unfortunately, if it happens, usually it happens after 10 to 15 years. If it happens, we have to find a new donor and do the second transplant.
So now when we're talking of second transplants, we also get, I mean, you must also see patients like they got kidney transplant done, rejection happened. Sometimes they get second. I mean, two of my friends, it happened with their parent like that. First kidney transplant was not successful, second was successful. So when our doctor partners they talk to us, they ask these questions. So now today is the time you cover, sir. So somebody got a kidney transplant and rejection happened, not successful, then they do it second time. So does the first rejection has any implication on the second, or is it like a fresh innings, like start the batsman going in to the
No, the
next?
second transplant is slightly higher risk than the first transplant, truly speaking, because the body is already sensitized with some antigen, but still it will have a better outcome than the dialysis. Okay, so slightly risk, it's not very high risk. And second thing, the immediate transplant problem, if it has happened very early and the graft has failed, believe me, their rejection is possible, but at the same time, the surgical thing also contribute for it. Doing a very meticulous surgery is very paramount here. So that's how the transplant techniques and transplant surgery, what I have shared with you is like you have to be very careful in handling your artery, vein so delicately, because any trauma to the kidney handle during the surgery can generate thrombosis. That thrombosis creates problem in the early phase. So the early phase rejections are possible. Along with in the early phase, what we can prevent is a good surgery, so as to prevent the early surgical complications and the graft outcome.
Okay. So we have next question from Dr. Ashitu. So thank you, doctor. And in the future, is there xenoplantation, yeah, xenotransplantation? In the future, is there a possibility that animal kidney like sheep to be used in human?
It is being tried, but I don't see lots of hope in the xenotransplant because there is problem in the tissue and into the microbes, the chance of getting parvovirus and other virus from the animals into it. So the success is still questionable.
With that question,
More than that xenotransplant, the success is happening into the artificial engineered kidneys. That is going to be a truth in near future.
thanks for covering that. So like the Star Trek kind of future, like if artificial organs, like biotechnology advancing, if they
Yes.
are human
So,
compatible,
so
that will be a blessing
it's
for the human.
it reminds me to a very recent surgery. What we have now started is like for the erythroplasty, the tissue engineered graft. What we are doing for the erythroplasty now, the erythroplasty surgery is a surgery for urethral stricture. Urethra is a 25 centimeter long tube in the men, and when it is narrow, it becomes problem. Then earlier the outcome was like doing a multiple OIUs or doing a erythroplasty. Erythroplasty is still a good technique. It is, but the more invasive thing. For those patients, those who have very small segment of urethral stricture, we do a tissue engineered buccal mucosa graft. So we take a little bit tissue from the cheek, around 5 centimeter or 0.5 centimeter, send that to the lab regenerate these cells. They grew that cell into the tissue culture. These cells we implant into the urethra. That is the recent advancement in the erythroplasty technique.
Great future ahead for medical science. Now,
Yes,
the
actually there is the merger happening between the technology and the biology. So the biotechnology people, they are putting their brain to create the more practical solution which are technology driven for the patients.
So there's a question from Dr. Innocent Nizili. Hi, Dr. Rana. Thanks for the presentation. How do one ethically navigate finding a living donor without pressuring family or friends? Dr. Innocent, law says that donor should be doing it out of love, compassion.
Yes.
So you cannot pressurize actually. But
So
doctor,
there is no question about pressurization. It happens because the donor, as it is, he or she will live a long life. So what we always say, it's a chance to become more healthier. That's how I put my opening statement to my donors. Okay, so you are getting a chance to become more healthy by the act of donation. Simply choose it, and most often they do that.
uh, so Dr. Innocent, basically what I mean, Dr. Rana can also touch upon it. In India, there are campaigns that educate people the benefit of organ donation because of our religious beliefs. Many of us do not. Like we face shortages of organs, and we keep hearing that. And when you talk about pressuring somebody, then that is not ethical.
So
That is
for
unethical.
that, actually, it's better to that the recipient stays on dialysis. Take care of him on dialysis. That's a good idea. In India, we do cadaveric campaigns. So the cadaveric transplant is something which is very close to my heart. There is really huge demand and supply gap in this field. More kidney transplants needs to be done. More organs from the cadavers we have to harvest so as to we teach our young students, their families, like the act of sharing. So what I always say, it starts with your healthy thinking. So if you take care of your body, then only you can help someone. First, investigate yourself. If everything is fine, take care of that. Unfortunately, if it any bad day happens, and if anything happens like that, don't shy away in sharing and uh, pledging your organ for the donation.
So there's a question from Dr. Ivan, Dr. Yajvendra. Could you help explain a scenario of patient with both hepatitis and they had transplant? And to add on to the question, what happens to the patient who had transplant? Okay, this is separate. So both there is hepatitis, some hepatitis condition A, B, or C, and the transplant.
ABIC, we have explained earlier, yes, hepatitis B or C, a recipient, because on dialysis, this is very, very common problem, like they develop infections. There will be some infection transmitted through the dialysis machines and all. The hepatitis B and C, nowadays we have good medicines for that. So once the patient, they are in the safe range of the viral parameters, we do a transplant and they carry on with their medicines for the hepatitis B and C for their future.
And so now his follow-up question is, what happens to a patient with transplant but there is delayed organ function?
Delayed organ function in live related transplant, it should not happen. So in live transplant, if there is delayed organ function, that means there is little problem into the organ harvesting. So here, that's why again to re-emphasize, choosing a good center, good surgeon is very, very important for kidney transplant. Okay, so in the live related transplant, delayed graft function should never happen. If it happens, then it should be managed in a proper way so that early graft function recovery can be the reality. For cadaveric, yes, delayed graft function is the fact, it happens. Here there are like we have to reduce the cold ischemia time, prepare your recipient in the timely manner so that you don't waste organ time, that window of around 12 hours. What we usually prefer that we do the engraftment within the first 12 hours. If possible, within 6 hours is the best. If not, within 12 hours, we have to aim for that. Somehow it's a kind of a wars kind of strategy. Everything goes simultaneously so as to reduce the delayed graft function. But if it happens, most often it recovers because these are ATN. ATN usually recovers. We have to modify the immunosuppression. We have to withhold the TEC, give them more steroid and the ATG. That's how they turn out.
So again, we have another question from Dr. Isaiah. Important, sir. Recommended diet recommendation post kidney transplant.
So post kidney transplant, what we always tell them, a properly cooked food, street food is big no for them. They have to be strictly with the hygiene and all that kind of stuff. Otherwise, they can eat normally. So they can eat chicken, they can eat all that local things available in their country, but properly cooked and hygienically prepared. That is the mandate.
Okay. Okay. A very interesting question from Dr. Boris. So let's say there is we did kidney transplant and there's a failure. So can that kidney be removed and used for another patient?
No, 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 never. We cannot. If the kidney has failed, that means there has damage happened to the kidney. That kidney cannot be reverted and put back into the donor, not at all. It goes into the dustbin then.
Okay. Now, again, another question from Dr. Isaiah. Have you ever come across a patient who needed kidney transplant for both kidneys? In this case, how do you handle this?
No, no, no. Kidney transplant, actually, we have to just transplant one kidney. So the bad kidneys, they stays back with the recipient. We only do the nephrectomy whenever there are risk of infections, kidneys which are very big, having stones in that. Otherwise, this small kidneys, they stay back with the recipient. We do the transplant in the iliac fossa and put only one kidney. It is not like we have to do two kidneys for the transplant. No, single kidney is good enough.
I think, sir, we have taken a lot of questions, overshot the time also.
Yeah, now a little bit about the oncology, which is also very close to my heart. I am a robotic oncosurgeon. So with the advancement of robotics, you see, this is a surgery of robotic prostatectomy. How beautifully we can do that surgery and remove the tumor out of the body. Only thing is, like, I cannot fast forward it.
No, it's okay, sir. I mean, I think sometimes visuals help.
Okay, if they are okay with it, I'll just show them how the dissection being done. This is the vas deferens. We are cutting it and doing the dissection posterior to the bladder. And you can imagine how deep the prostate is. This kind of procedure is like when I was doing the laparoscopic surgeries few years back, 7, 8 years back. I used to stand like holding the instrument like this and lots of strain on my shoulders and doing exercise afterwards. But now sitting comfortably, doing this surgery very deep in the pelvis comfortably. So it gives the comfort to surgeon as well as patient. Patient also quick recovery. Surgery in the laparoscopy used to take around 6, 7 hours. Now within 4 hours, skin to skin, we are able to finish everything. Sometimes in a good prostate, maybe 2.5 hours, 3 hours. That's it. Okay, that's how the dorsal venous complex (DVC). Very deep. It is into you can make out here are the pubic symphysis. Deep into the pelvis, how the pubic bones, and we are doing the surgery here. Now here the prostatovesical junction is being opened. Here is the prostate. This is the bladder. That's how it happens. So now I'll skip it and show you something more into the other surgeries. Like the bladder, for the bladder tumor, sometimes we do radical cystectomy and neobladder creation. And the partial nephrectomy. This gentleman, he was from, okay, very interesting story. I'll just share with you. This gentleman came to us from Tanzania. He had bilateral kidney tumor. You can make, here is the tumor here, and this is again a tumor here. And there was some mass in the adrenal gland. So he was labeled as metastatic disease, like nothing can happen. Your both kidneys had tumor, your adrenal has tumor. Now you'll go with the just immunotherapy and survival of 1 year maximum. But it was not, I no, was not very convinced about the diagnosis. I thought there are small tumor bilateral and the tumor in the adrenal, still resectable. Let it be metastatic. I explained him that in one surgery I'll remove all 3 sides of the tumor and let's see, and hoping that it cures you. So we did that surgery, and this surgery, now he is almost 5 years. There is no tumor in his body. So he's just a single case like that. But I have done multiple patients, those who have bilateral tumors, and we did surgery in one sessions robotically. Both side kidneys are saved and tumor removed like this. So that's how, with the advancement of the technology, patients, they get better care. So that this is the small video of partial nephrectomy. Here the colon mobilization happens initially. After that, the pedicle dissection. This is the video of Mr. James from Tanzania. Mogambo, I remember like this. That's how the ureter is being dissected. So any question we can discuss here also, no problem. So I'm dissecting here the small lumbar vein. This is the renal vein here. This is the gonadal vein. That's how the artery being hooked up. This artery and the vein will be now looped. You see how beautifully the dissection being carried out with the help of robot. See the artery, renal artery. Yes. Now here comes the kidney tumor. So this tumor was barely visible here. This you can make out. That's how the normal kidney parenchyma, and this is the tumor. This is around 1.5 centimeter exophytic and more than that endophytic inside. So a few days back, I just removed a tumor in the hilum only. So very difficult location, but patient is doing quite well and everything is fine. We have discharged him. That's how the artery gets clipped with the bulldog, and the dissection of tumor will start now. Now we do firefly fluorescence just to delineate the tumor, see the vascularity here, and cut that. Okay, you can see. So how the tumor is like. Just 1/3 is outside, otherwise the whole tumor is inside the kidney. That's how whole the tumor is being removed. Looking interesting? Are you guys excited to see this kind of surgery?
I think, sir, the surgeons or doctors here should answer that.
Yeah. So we could save a whole kidney now. See this, beautifully done. That's how the rhinography will be done, and we'll stitch this kidney and the whole kidney is safe now. Okay, so this was again a very big surgery, robotic level 4 IVC thrombectomy with radical nephrectomy. So for the paucity of time, I'll not show this video. And as you all know, what are the benefits of robotic surgery? Yes, greater precision, faster recovery, less pain, reduced risk of infection, minimal blood flow and transfusion rate, and small incision, quick recovery, patient goes back home early. That's how the thing is. So
one of these topics, like where you showed, like, oncology is in itself is a very important topic. I think in one of the follow-up sessions in future, maybe like you covered in detail, the
no
advanced.
problem. We can have a case discussion, whatever they say. So definitely,
I
there is
think
no
because we
problem.
had to rush through it, but it is an important topic. Because of
Yeah,
positive.
the cancer itself. So actually, in nutshell, in 1 hour, I have covered whole urology spectrum, starting from basics, stones, advanced robotics, and the kidney transplant. So the whole idea was like we have the galaxy of the equipments with us with the advanced technology, and your patients are very safe, and we promise them a best recovery. That is for sure. And in my end, it's my humble beginning, and we'll begin now with the collaboration, better collaboration for better patient care through Jivo Health. You send your queries, we'll stay in touch, share the patient's queries also. And whenever you feel like there is some medical discussion, you want to discuss some case, I'm just a WhatsApp call away. So
Thank you,
can
sir,
you?
for that last thing, because many times, as you know, African countries are also developing like India. Like while we are discussing this excellence, but in India, this excellence lies in metros, Delhi, Bombay, and Bangalore. But if we go to like Sonipat and Bagpat, the situation uh, uh,
Yes.
is very bleak. So the thing is, many times, I mean, doctors discuss with us also these interactions. They help them. Many times, patients are poor, but these master classes or sometimes opinion from a specialist like Indian specialist, they help them understand this better. So what we do is typically we follow this process. We ask them to document the case, share it with a specialist like you, and we
Yes.
agree on a time. Like Dr. Hivat from Ethiopia is here. She is a rheumatologist. So
Okay.
a few of her patients, with a rheumatologist here. So that's how they are able to manage the case better. And thanks for giving this comfort because we all want the healthcare excellence or the knowledge share so that maximum people benefit. Thanks a lot for that.
Perfect. That's what I believe, right? Knowledge should be shared across. If I know something, I'll tell and teach everyone about that. I'm ready to get the knowledge from all of you also. So, whatever field you are expert, we should actually share the knowledge, and it helps eventually for our patient, for our humanity, and everybody. So, let's make the earth a better place for everyone, healthy and
Yeah.
healthier life.
And sir, in today's world where technology connects us, like in Delhi, we need a cab, just 5 minutes, it reaches our doorstep. We need
Yes,
medicines, tests, anything, 10 minutes delivery, 15 minutes delivery. Healthcare is very important. And
yes,
the only thing which is lacking is, the expertise that flows. And at Jivo, what we are trying to do exactly that. Like even in your case, let's say a patient comes to you, if it is a multi-specialty, it's admitted in a multidisciplinary way, you collaborate with, let's say, if neuro and urology, they combine, probably you and Dr. Consult together treat and handle the case. So similarly, what we are bringing is to our African colleagues, doctors in Africa, practice in Africa, that Indian
yes,
expertise is accessible to you through your phone, through these interactive events, through a structured process, and
yes.
more patients benefit from it. And so there are many compliments for you. Should I read them or share with you later over chat?
Whenever, right. If
Okay.
any question, I'll be more than happy to answer. Otherwise, we'll close this session now.
Okay. If you have any questions, you can share. But if you have any follow-up questions, like today, tomorrow, or even after, on your Jivo work group, you can write that question, and your relationship manager, they will structure it and share it with Dr. Rana's team, so that we will get a response within a reasonable time frame from him.
Yes.
Thank you, Dr. Rana, for taking time out on a Sunday. Sunday is the
Thank
only
you.
day doctors get for their family when there's not an emergency in India. And I think it's largely true for our African colleague also. Thank you.
Yes.
Thanks a lot, all of you, taking time out on a Sunday, attending these sessions. This is a very small start in what is future of doctor collaboration across borders and how healthcare delivery can change. Dr. Rana also demonstrated that a lot of part is if two doctors are connected across border, it's just not one-time surgery. It's a long
Yes.
follow-up. If two
That's
doctors,
true.
local doctor and an Indian specialist, they are connected, it is always better for better recovery of patient, realizing maximum health benefits of the surgery. And thank you all for your time. And thank you, Dr. Rana, for
Thank you very
giving
much.
time for an extended session. We had taken a commitment of 1 hour. Thank you. It's close to 1 hour 45 minutes now.
No problem. It's like goes on. Once you start discussing, yes, at the end, both should learn something and help our patients.
And thank you everyone for making this session interactive because
Thank you very much.
that's
Thank
the
you.
joy. I mean, the experts come and interact. Thanks a lot. I am ending the meeting now. And
Thank
any questions you have for Dr. Rana, please don't hesitate to ask. Any case discussion, forget India referral, any related to
you.
this field,
Yes,
any case notes that you want to discuss. Of course, if you have any patient to refer, you initiate that. But any case notes that you want to discuss, please feel free. And also, if you can tell us, we can discuss with Dr. Rana what follow-up topic from his specialty we can cover in next masterclass whenever we can get his next availability.
right, right,
Thanks a
right.
lot.
Okay, thank
Uh,
you, everybody. And now I'll sign off.
Thank you.